meeting to order. Thank you all for joining us today. We are going to pass around sign-up sheets. There's 2 sign-up sheets today, different than normal. We need to go ahead and have you sign in for both. One is for our community advisory council here in Lake County. The other is for EOCCO for their presentation. So thank you, EOCCO members, for being here today with us. It's exciting to have you make the big journey out to Lake County. I think we'll start with just going around and introducing each other. That's what we normally, ourselves, rather. Might be more fun if we introduce each other. So I will start. I am Susan Pointier. I'm the Lake Health District or New Cycle Manager and Chairperson for the CAC.
I'm Janet Holland, Director of Integration for EOCCO.
Hi, I'm Arvind Singh. I'm the Community Health Coordinator for Lake County Vista District.
Hi, I'm Patrick Mulvihill, Communications Coordinator for Eastern Oregon Coordinated Care Organization.
I'm Diane Clay, and I'm a consumer advocate.
Cece Montgomery, and I'm with wherever.
Yeah.
Those who know me know it.
I'm Helena Van Brand. I'm the Food Corps AmeriCorps Service members in Lakeview.
I'm Heidi Martinez. I'm the Clinical Supervisor at the Lake District Wellness Center.
I'm Dr. Wanja, and I'm the Executive Director of the Wellness Center.
I'm Jackie McDougall. I'm ENCC and Case Manager at the Wellness Center.
I'm Jill Freeman. I'm the Care Coordinator at the clinic.
I'm Kaz Baum, Lake County Senior Center Transportation Coordinator.
I'm Carrie McLean, and I am the Clinic Supervisor.
Christy Albertson, I am the Grant Writer and Coordinator for Lake Health District.
James Williams, Lake County Commissioner.
I'm Kristen Hill. I work for Lake Health District as the navigator.
Renee Baker, Lake County Senior
Dale Pardue, Warner Mountain Medical Clinic.
Miyuki McMullen, Food Share Warehouse Manager.
Anna Marie Dent, Concerned Citizen.
Sam Huddleston, Concerned Citizen.
Deanna Fullstone, part of the crew at the food pantry.
And Kevin?
Oh, sorry. Kevin Winter, Examiner and Reporter.
Do we have anybody on the phone?
And I'm Noah Peets. I'm the Medicaid Professional Relations Director at EOCCO.
This is Alan Flood with the Lapine Community Health Center.
I know why she's working on that dinner tomorrow night.
And how Vanessa can go to Yeah, it's the connection isn't great, so I'm going to do the best I can. Thank you.
Hello, this is Vanessa Pingleton with the South Central Early Learning Hub and Community Uplift.
This is Jillian Wilkenberg. I'm the director of the South Central Early Learning Hub with Lake, Klamath, and Douglas, and I'm housed at Douglas Senior Service District.
Yes, Paul, we are doing the introduction. Can you hear us now?
I think so.
Oh, okay.
Good afternoon, it's Stella Gomez with OHS.
Can you hear us now, Paul?
Yes.
Okay.
So we started the meeting, Paul. We are done with introductions on our side.
Sorry, we didn't know you were muted.
Patricia Park here also from and Irving.
As well. Start over here. Oh, yeah, I'm Titus Roman, and I'm on the health report. Robert Johnson, Polk County and Town. Paul McGinnis, Eastern Oregon Coordinated Care Organization. Otto Sunlight, North Care Transportation. And we're likely to have Dr. Allen joining us. He's the medical director for the Lapine Community Clinic location in Curtis Valley. So I'm going to get started. You can bring up the slide ahead and share.
Well, do you want us to go through our agenda, or do you want to start with this piece first, or what would you like to do?
Oh, go ahead and do your small. I'm sorry, I forgot. Call me back with you.
Okay.
It is very hard to see you guys on the phone.
Okay, hang on. Do it, hit that
Should we
microphone.
move this thing
There you go.
closer or that closer?
Okay, can you hear us better now that we have the camera shut off?
I can hear you, but I can't hear people that are farther away from you.
Okay.
So we'll repeat. We'll do our best to repeat what people are saying.
Okay, thank you.
Whoever's speaking, we need anybody that's speaking to be near that mic, because all of a sudden you guys sound quiet.
Oh, that's because I'm putting the mic on.
Yeah. There's a lot of background noise, so we're gonna mute you for part of it, and just, would you just use the chats to, if you need to comment?
All mute me.
Oh, thank you.
I don't know that.
Okay. So we'll take just a moment for everybody to take a look at the minutes from the last meeting, make sure we don't have any corrections or additions. Is there any additions, corrections? If not, we have a motion to approve the minutes.
I'll pass the motion to approve.
For a second?
Yes,
Thank you, Kristen. All in favor?
Aye.
All right, minutes accepted as presented. Arvinder, do you have some chip updates for us?
Yes, thank you, Susan. I'll try to make it quick. So this week we completed our 6-week session of the Living Well classes for diabetes. We had 3 participants who completed the session and they got the completion gift certificates. Next, we plan to conduct a Living Well class for chronic pain. And our plan is to end that session before the end of February. The next update I have is for the teen health fair. We had the teen health fair yesterday at the Dairy Middle School gym. The teen health fair was conducted under the Transformation Community Benefit Initiative as an opt-in project. We had 9 stations which included dental screening, immunization, mental health, ranging from those to nutrition and library. And we also had a lot of giveaways for the attendees. So far, my estimate is that we saw around 90 students. I've been able to go through 54 of the passports. And passport is our way of tracking the number of students that have attended the teen health fair. In the passport, we had asked a few questions. One of them was if they would want a health fair next year. As the funding is going to stop, we are not going to have funding for next year's health fair. This was our 3rd year of conducting the health fairs. So it was just our way to find out if the youth of Lakeview feel value in the teen health fair and they benefit from it. So, so far of the 54 passports that I went through, 52 said yes, which tells me that whoever attended the health fair had a good time. But of course, we could have had a larger turnout as all the stations were prepared for anywhere between 150 to 250 students. The hospital started advertising for the health fair 3 weeks in advance. We did weekly ads in the newspaper, the radio, Facebook announcements page. We also put up posters at the school. And we also had teams of students that presented in all the classes, giving them an idea of what to expect at the Teen Health Fair and what all stations will be there. So, yeah, so that was the update of the Teen Health Fair. Then I have a few quick just information I wanted to share with the committee. So there's gonna be a harvest dinner at the Methodist Church tomorrow. And it's going to be from 5 to 8 p.m. And it's open to everyone. Oh, we can hand out, and I can always make a copy and,
Yeah, I don't have too many copies left. but-
yeah, so I can give
I can
everyone.
some copies away?
30. Yeah.
Sure. So we have the harvest dinner tomorrow from 5 to 8 p.m. On November 22nd, there is going to be a Thanksgiving lunch at the Senior Center. And again, in the hefty packet that I've given everyone, there should be a flyer about the Lunch and Learn event. Yes, that's the one. So it's the Lunch and Learn event. It's brought to us by the Community Uplift Agency and the Take Root Parenting Connections Agency. Community Uplift is a non-profit that seeks to provide stability and support for youth and young adults who are experiencing a life crisis. And the Take Root Parenting Connections is a group that is based in Douglas County, and it's a form of parenting support for Douglas, Klamath, and Lake County residents. So the Lunch and Learn event.
Thank you for connecting.
Oh, absolutely.
This is Vanessa Singleton.
Yes, hi Vanessa.
Can I ask just a little something there to the Community Uplift?
Absolutely, Vanessa, go ahead.
Community Uplift. So Community Uplift is actually, it is connecting expecting parents and children 0 to 5 or up to the age of 21 to resources that they might need, such as some of your early learning providers there in Lake County, and we can connect them to KCC, those services, mental health, those kinds of services. And it was actually built by people right there in Lake County. So Jill Harlan and Vicki Taylor, your lady used to do your Healthy Families there at Lake District Hospital. So we just kind of want to show your community what we've built and what's available to you guys.
Nice. Thank you, Vanessa. And again, the Lunch and Learn event is on November 20th. It'll be from 11:30 to 1 p.m. And it's going to be in this room, the Penn Wilbur Conference Room. And it's a free event, and it's going to educate about services and support for expecting parents and for children ages 0 to 5. Next, Elena, do you have any food court updates you want to share?
Sure, so just briefly, because I know I've got a lot of things to get to, so I'm in the classrooms usually 5 days a week. I'm teaching nutrition and just general food education, trying to work with the gardens too, or on expanding gardens in Lakeview anyway. And also like update Teen Health Fair wise, yesterday I did have a booth there as well, and that was the nutrition booth. And we did green Hulk smoothie, and actually the ASB president actually helped out a lot in making the smoothies, and I think it was a pretty big hit. And
Thank you.
thank you.
I think that's all the updates I have.
Christy, do you have any grant updates for us?
I do. Somewhere in your packet, or possibly loose on your chair, is this 2020 LCAP document. A group of us met a month-ish ago to talk about what all we might want to do with the LCAP dollars that will be coming to Lake County next year. For newbies, or just as a reminder, Lake County did well meeting some of EOCCO's targets in 2018? Yes, 2018. So this funding that we have, which is a little over $41,000, is comes to us because all of our clinics and our team did very well in meeting these incentive measures. So the grant has changed from in years past. We're not addressing incentive measures in this grant. We're looking at what y'all decided for the LCAC 5-year plan. So one of the priorities that was identified in that plan was food insecurity. And so some of the ideas we talked about in that, we would like to and have applied to host a Vista service member here. We've had a couple so far, similar to what Helena does, service work through AmeriCorps, basically. And the Vista would help us with several things that this group has identified as being important. One of them is that we know we have a hard time reaching out to areas outside of Lakeview. All the services are down here, and so it's hard to get engagement and to really understand what the needs are in Paisley, in North Lake, in the Warner Valley. So we would like a Vista to conduct listening sessions in those communities and figure out what the people think their needs are, and so that we have a better idea as the LCAC about how we can bring programming or support programming or just give people better access to care and opportunities to live healthy lives. The Vista also would be working with our food corps service member and the Lakeview School District and our leader to figure out a sustainability plan for food education in the county. Right now, food corps is limited, just because that's the way the program works, to our elementary schools in town and at Union. And food corps is not meant to last forever. We need to graduate from that program. So we want the Vista to help us figure out a 5-year plan to sustain what the food corps service members have done to date and see if there's a way to expand that kind of education to the rest of the county. The other piece that the Vista would help with is work with this group to use what she's collected, I say she, but he or she has collected from the listening sessions to help us design programs and projects and help with a grant strategy to figure out how to fund things that are truly going to reach the entire county. So that, you can see the cost is about $8,900, and what all is included in that is mileage for this person to travel. It's to pay, the health district would host this person, would be responsible for making sure they have a computer, phone access, what have you. It costs something to host a Vista, and so this is to help cover the expense associated with that. Presentation supplies for when this person goes out into the community, so that is all included in the $8,900-ish. We, at that October meeting, we talked about continuing to support junior park leaders, junior program leaders as part of the summer lunch program. I don't have the numbers written down off the top of my head. I know that we have more than doubled what the number of lunches we served in our first year, and we were up 7% over last year. So having these kids, almost always kids, high school kids, help us prepare lunches, hand out meals, supervise the sites, we found that that works better than having volunteers. We love volunteers. Please volunteer with the lunch program and show up. But having consistent staff throughout the summer both takes stress off of our vendor. We don't want that head of hair turning gray, worried about whether people will be there to serve lunches. But it also gives the kids and families who attend, they have familiar faces and people they bond with. And the kiddos have these key leaders they look up to. And so that's been a very positive experience having the staff. And then the amount here is the minimum wage for 3 program leaders during the summer. The number 3 under food insecurity is a maybe. I don't know, it was in the paper, but if you haven't seen it or heard, Lakeview High School, Lisa Schulenberger and Christy Reese have funding to try out a backpack program, specifically over Thanksgiving and over Christmas. And there's been a lot of talk in this group and at the school about the need to have just a backpack program in general so that kids who might not have access to food over the weekends will have backpacks filled with just pre-prepared stuff that, they don't have to handle knives or anything to make sure that they have food over the weekend. So the school district, they want to see how this test run goes over Thanksgiving. They have, I want to say, about 30 families interested in this, so we'll see what happens, and then we're going to meet with Lisa and Christy after the holiday and see if they want to move forward with this. They're modeling it after, I can't remember what county, but the county, do you remember, Kristen, what county? It was Hefner, okay. And it costs about $15,000 a year for Hefner, and Hefner's close to our size. So $8,800 is not enough to cover it, but it might be a start, and maybe we can help them find other grant dollars if they're interested in making a year-round program. The next one is another priority that we identified was the idea of early childhood abuse and trauma and substance abuse, addiction, those issues. And so one of the ideas is the idea of bringing Sources of Strength or a similar program to our schools in Lake County. Sources of Strength is a suicide prevention program, and essentially you train at least 2 facilitators in your county or in your school, and those facilitators train adults and kids in the schools, and those people are mentors, peer mentors and adult mentors, to add resources to kids, so they have more people to go to. Because mental health, we don't have a full-time presence in any of the schools, and our school counselors are strapped, and frankly, suicide and suicidal ideation is a real problem in pretty much all of our schools. North Lake in particular has said this is a need. So this is, I mean, I listed pros and cons of this. It's pretty expensive just to train 2 people. It's $5,000, which is about all we would have grant funding to cover. You'd also have to pay the facilitators travel, airfare, hotel, etc. It's low to the schools if you want to keep participating in it. It's only $500 a year for them to keep going. Whoever our facilitators are would need to be recertified. It's every 36 months or something, so there would be additional expense down the road. We also don't know, this program is really set up for larger schools, frankly, where the idea is that you send a couple of people from one school to get trained to serve the needs of that one school. So we're considering looking into, if this group thinks this is a good idea, we would look into whether another entity, whether it's the ESD or youth mentors or juvenile probation or someone could be the host for this. ESD would be the perfect candidate. I don't want to volunteer Jack for anything, but those are the options that we're looking at. So other costs, the group wanted to continue to support the Outback Strong website. So that's about $300, and that's the domain name, the web hosting, and we have a couple of email accounts set up with that. Our vendor and I, our staff, our positions are grant funded in theory. The health district has been really good about covering our time, but we're involved with projects and programs that don't bring in money. And so if we have grant dollars to support the work that is actually happening, that is a goal. So we have some funding there for our vendor and I, and then just the indirect grant administration costs are there. So that's a tentative plan, and I just wanted to throw it out to the team now and get a general yay or nay, like what do you guys think about this? Speak at once.
I think this is a great way to fund our junior program leaders. I know that's been really a positive thing for the kids in the summer lunch program. So, and I know we've struggled for a long time to find ways to sustain those costs. So I think this is focusing on the food insecurity is a great way to start that. And the backpack program is awesome. I think the folks up in North Lake County do that, and they've been pretty successful. I know they have different needs than we have here, but they have been successful. So that would be, and we have a lot of elementary kids, but if we could find a way to sustain that long term, I think this is a good start.
Okay, so next steps wise, if you have any comments and don't want to speak now, or if something occurs to you at 2 o'clock in the morning, just shoot me an email or give me a call. Timeline wise, at our December meeting, this group has to vote on, I will have a draft to everybody, and this group will be voting on whether yay or nay.
I also need, before the end of this meeting, actually right now, often what happens is I am the only one who sees the grant proposal. I take all of the ideas and whatnot and put them all together, draft the budget accordingly, and then we send it off and hope for the best. It would really help our success. It would just be better if there were more eyes on that application before it gets sent. So I need 3 to 5 volunteers to proofread this thing and point out any errors of any kind or make suggestions, etc. I'll volunteer. Awesome.
I'll review it. I'll review it.
Thank you. Sweet. Anybody else?
As long as you promise to send us emails reminding us that we have to.
Oh, you know I'm gonna send emails.
As long as you mom me.
So for you three, by the end of the calendar year is when the final draft will be finished, and then I need to submit it. My target is January 15th, the due date is the 17th. I try to account for squirrel-related internet mishaps, so try to get it in earlier. Cool, thank you all.
Can I also volunteer?
Yes, you can.
Okay, so I'll add my name also.
I have a question about the ACEs. Will there also be training about what ACEs are, intervention, and how it relates to trauma? Just the seem to only take one aspect of it and not the whole.
Correct.
All the concerns.
Correct. And that's, I mean, we have X amount of funding, and so that is on the ACEs and trauma-informed care. All of that is part of the 5-year plan. We actually looked at trying to get train the trainer, trauma-informed care, train the trainer training. But what I heard from our vendor who attends the parenting hub, those meetings, and then Daphne Greer, both said that, oh, and Amy Hutchinson from the library was there as well. And I heard from these folks that there's definite interest in bringing train the trainer here or getting people trained here, but there was no interest in actually sending local people to be trained. So that's where that one ended and why we started talking sources of strength or a similar program instead. That's it, it's a 5-year plan, so there's
five people that wanted to do it, and then we get people from other counties that are gonna to do it. Because we're like our section, the state is one of the ones that are doing it when the rest of the state is all involved in it, so that's concerning.
Sure.
And when the director came to Lakeview, he said there's a definite need for this training in this area. So that's another thought. And I could come up and do individual trainings as a group, but it'd be nice if there's cross-sector and there's champions and everybody was on board and understood.
Right, and at this point, we don't have that piece, the cross-sector. Our mental health, you folks went through trauma-informed care training last year, ish. We've had some training here, but there hasn't been any, as far as I know, no one has, and we did specifically ask the parenting group, knowing that you guys are interested in this and want to make this happen, but we don't have that cross-sector support at this time.
Okay. Because even though there is training, there's not the policies and protocols and procedures and all the steps to put this in place. So there's been training, so there's awareness, but it's still a huge issue just to put that out there.
Right, and it is, our plan is a 5-year plan, so it's definitely, we work on building the support, and this isn't the only avenue, funding-wise, that we can use to try to get that. But we'll need the parenting hub to really champion this and take the lead to make this training happen.
Okay.
Okay, we also have on hand, we have a little bit larger group than normal, so we always like to remind our community members that we do have our Community Advisory Council applications on hand. We'd love to have anybody from our community join so that we can grow and have more additional input. And from there, I don't know, can Paul hear us?
We can hear you fine.
Perfect. Do you want us to share the screen before the PowerPoint, or how do you want to move forward here?
No, bring out the PowerPoint, share the screen after it's up.
Okay.
And I'll turn it back over. It's Jan, right? Robin is not there? Where is?
Yeah, I'm here. We're pulling it up.
Click the mouse.
It might not work on that. Our mouse is broken.
He's a little, he'll stage fright, it's okay. Can you have?
Mice are known for their bravery.
There you go, Brandon.
Touch your mouse.
Okay, so we're not really talking about batteries. Hang on, we have some batteries.
Is the mouse on?
Yeah.
I'm supposed to go home.
We're changing batteries. Everything works. We tested it out ahead of time and it's always.
This is never.
Needless to say, there's food and beverages in the back if you need to.
Where are you? There you go. It's just being really slow so they feel like. Now your mouse is working.
Maybe it's too far away.
Magically so that it was working. Okay.
So, Paul, you don't want us to share the screen with you?
What's that?
Yeah. Do you want us to share the screen, Paul?
Yes. PowerPoint up.
Can you see the presentation, Paul?
Go to the first slide and go to the, yeah. Up the top of one. There we go. Very good. All right, so everybody, thanks for your patience with our technology, but at Christie's suggestion, last month, we're trying to accommodate some folks in North Lake. This was the best piece that we could see on the building. Picture of our service there, next slide. This is a, next slide, this is a required contract that the Eastern Oregon Community Organization got from the Oregon Health Board. We are asking to make the public the use of our 12 counties. All CCOs, Oregon Care Organizations across the state are making this facility that requirement as part of the annually amendment. So what we're here talking about, we're going to call it what it was called, CCO 1.0, because it wasn't 1.0. It was just coordinated care organization. Now we have 2.0. So we're going to share with you what would happen in the past, what we're supposed to do in the future, and getting input for people at the party. Next slide. We're at a point, we just want to be able to be respectful of one another, not talk over each other, one person at a time. Although it says wait for questions at the end, clear and quick questions are welcome. Comprehensive discussion will hold to the end. So, we can go from there. If you can go to the next slide, Raymond. Who we are is, we first received a contract with Medicaid services. Each one working in 12 counties that are listed there. Left 4 outside of the state of New York. Total population of about 200,000. Went over that from the Center for Population Research and State estimate 2019. 200,000, 12 counties, 550,000 there. Next. The Eastern Northern Coordinated Care Organization is a corporation. So it essentially, even though it's nonprofit, it acts like a for-profit business, and there can be dividends and calls for payment by the owners. So the ownership involves OES Community Health, which is Moda Health at 29%, Greater Oregon Behavioral Health at 29%, a number of our independent hospitals, later on here we'll talk about 5 hospitals that are related to health districts. Because for public entities, they weren't able to enter into the district to take this to the law. And then that model farmers, and independent physicians association. So essentially what happens here is if we lost $1 million, health and Greater Oregon State or health would have to come out with $290,000 to make us good. Because we're on a global budget of the we do have a government board that represents broader than just what's listed here. It includes representation for local hospitals, so the 5 district hospitals get to, among their administrators, pick somebody who has a seat on the board. You have public health representative, mental health provider, and 2 community advisory council. That the chair of that, whoever's elected chair automatically has to place on the board. So we'll go to the next slide, please. You essentially have 2 ways to communicate and share your opinions with Eastern Oregon Coordinated Care Organization. On the left-hand side is the local community advisory council. That's what you were just hearing as part of the meeting. Lakeview, that's the regular business. People are allowed to get in there. They move agenda items forward, participate with the Regional Community Advisory Council, which is the chair of the local Community Advisory Council. In this case, Susan, and the county commissioner, in this case, Dave Floyd, and our vendor, who's at the meeting, serves as a proxy of our candidate to the advisory council. So all 12 districts are forward and carry out their issues. On the right-hand side of the group, you have so if you have issues with how people are paid, what the contracts look like for issues, what the quality measures are, and those kinds of things, this is the channel where you go through there. It is overseen by the U.S. Right. You go to the next slide. And hopefully our vendor distributed this because it's too small for the screen. But this slide is very important. We'll start right at the top. It says Center for Medicare and Medicaid Services, CMS. Let's not get confused between the programs. Medicaid is a program for people who are eligible because of income limitation. It's a partnership between the federal government and the state. For people age 65 blind and disabled, run entirely by the federal government, nothing to do with Medicaid. But if Medicaid, they say states, we want to have a program, yes, these states will give you this much money, they match, so we have a requirement. The Medicaid program in Oregon is run by the group below that, and that's the Oregon Health Authority. And the law that created the Medicaid program, there's section 1115 where you can ask the federal government to do something. And so you'll hear this term every once in a while, it's 11, 15 later. And Oregon's been doing something different for 30 years. When we first drew the line on services and said we won't pay anything about that, so we can cover more basic care. Well, we said we wanted to do these coordinated care organizations. We wanted to give a global budget to these people, which means you get a set amount of money, and if you work it, you win. If you can't, you're going to lose money and potentially lose the contract. So we're at this year. Again, the next part around the board of directors. Jim Williams is the representative on the board of the EOCCO that represents the Lake County area. Just want to give you the names of the clinical advisors panel in case any of the providers wanted to know or see if they knew any of these folks. We also have a regional opioid prescribing group, and that was there to deal with ongoing opioid crisis in that. We have dental care organizations, two of them, Vantage and ODS Dental. Over on the right-hand side, we have support staff over about high. That's people from Mobile Health and Greater Behavioral Health, myself, and where that office is. We have some pretty new names on moderate, and we deal with a little bit more health equity, social determinants. And also on the lower left, we have a legislatively mandated kind of expectation that we work for early birth. We have lots of large health plans. We do have a regional health plan and a community health plan for each of the local community councils. They conducted a community health assessment, decided what they wanted to do. And that's what Christian was talking about, food insecurity, ACEs and childhood trauma, and a number of other issues for the overall Lake County area. Next slide, please. So that's the organizational structure, but who actually does the work of the research and processing claims, those kinds of things? These are the folks who do that. Mother health, processing physical claims, regular behavioral health, mental health, behavioral health, claims that are the Oregon prescription drug programs, helps us keep our pharmaceutical at an affordable rate, and then with dental is advances in ODS. Next slide. So our membership, vacancy, but at the bottom of this it says 50,000 members. Each Northern Coordinated Care Organization. So that's 1 in 4 of 200,000 people in the 12 counties. 1 in 4 people are members of this program in each Northern. Here in Lake County, we can give you the data interested, but we break it out by age, gender, and zip code. For the southern part of the county, there are 1,282, and there are 672 EOCCO members in the North Lake zip code, Salt Lake, Christmas Valley. Total 1,954 members. So basically 1 in 4 people in Lake County as well. And we're going to move to CCO 1.0, and we're going to leave ourselves up here and listen to leadership present. Thanks.
So first, again, my name's Janet, and I want to say that unfortunately Kevin Campbell couldn't be here, who is the CEO, and Sean and Jessica, who's the president, were unable to make it, and so Noah came to help support us, and so we're really thrilled about that. If you want to go to the next slide. So what we want to talk a little bit about is where we've been with CCO 1.0. As Paul said, we're looking a little bit back so that we can also look forward. So the successes that we had for 1.0 are actually that we met the 3.4 rate growth. We implemented value-based payment models, which we'll talk about a little bit more, but those were really about shared savings, capitation, and primary care, patient-centered homes, PCPCHs, and the payments to those, which you'll hear about the investments we made in those. We also met the Coordinated Care Organization quality measure targets, which meant that the investment that we made then came back in, and we'll share those numbers with all of you. And those reinvestments were really then at the local community and resulted in things like community health worker training and reimbursement. We've got the community benefit initiative reinvestment and LCAC funding, as well as health information technology. And we'll talk about each one of these a little bit more. So the provider delivery network delivery system that we have currently includes Idaho and Washington. And so this is where we're at. We have 57 widely dispersed clinics. We have 24 rural health clinics, 7 FQHCs. 15 of the clinics are tied to health districts. And over 90% of the members are actually receiving their care in state-certified PCPCHs, which was a huge milestone and accomplishment, especially given the dynamics in Eastern Oregon in order to meet all of those requirements. So we're really proud of that.
So Janet, before you go to off of the clinics, just to clarify for people there, the La Pine Community Health Clinic up here in Christian Valley is one of those federally qualified health centers. The health district up here owns facilities and operates kind of as a landlord, as it works that way. And it is also a tier 3 patient center. Oh, you're 4 now, I'm sorry. They're a tier 4 patient center primary care home up here, down in Lake County, or down in Lakeview. Warner Mountain Clinic is a certified rural health clinic, as well as hospital operated primary care Lake Health Clinic. So I just want to make sure people knew who was what.
And
No, I mean, that's pretty much.
and Lake Health is a tier 4, Karen?
I think they are.
They're tier 4.
And then we're really close.
PCPCH
We should be
certification.
by the end of this week. Done.
Oh, great. So there are 10 area hospitals. 7 are type A critical access, 5, as we talked about, type A health districts, and really tertiary hospitals. So the behavioral health providers that we have, again, this is the entire network, and I have some disclaimers on this one. So when we put this together, in terms of mental health, there are 40 outpatient mental health, 9 acute and subacute. And this, again, some of these are not necessarily in our region. So I just want to clarify, I think that's been an area of like, well, people have asked, well, where are those? These are access, you know, so I know that most of folks here end up going to Bend. And so those are the areas, again, but we have access to them. There's also 1 children's mental health residential facility, and then 7 specialty clinics, which have a range of services, including eating disorders and things like that. For substance abuse disorders, we have 26 outpatient services, 10 substance abuse disorder residential facilities, and the detox one is now down to 3. So I just wanted, that is actually one of the facilities just recently lost their certification, and they're in process of getting that back up. And so that facility was ELAF naturally in the region, and so I know that it's created some challenges for folks in terms of being able to access. So we are actively working on a plan to help support that process. And then there are 13 medically assisted therapy or methadone. So in terms of dental providers,
Yeah, so in terms of dental providers, we do have 2 DCOs, which is ODS Community Dental and Advantage Dental. Specifically down in Lake County, you guys have access to Advantage Dental. Not everybody has access to both the DCOs in every county. So the biggest thing on here for the dental practices is more of a prevention care. Instead of just drilling and filling, they do a lot of education-based background. They also have dental care programs that include the first 2 training taxi for primary care settings, and then expanded practice dental hygienists, which are in schools for dental screenings. And then something we'll see more and more moving forward for 2.0 is teledentistry, which is more of like a virtual visit, something you can do over the phone or through an iPad, where they can go ahead and instead of going into the DCO or to your dentist, you can go ahead and get treatment over the internet.
So for non-emergency medical transportation, or we call it NEMT, because we, of course, love acronyms, those transportation services are operated through Gobi, and I think the important thing to note is the number of rides provided in 2018 was over 70,000 rides that were provided. Again, we recognize that a lot of folks have to travel distances in order to access certain levels of services, and so I think that is why that number is so high. We listed all the numbers in case you want to have them.
Yeah, and I could just add, this NEMT does a little bit more than just provide transportation. We also do reimburse if you need to travel yourself. If you have your own transportation and you drive over 60 miles, they'll reimburse per mileage on that. And a lot of this, for these rural areas is, as we stated in the hospital section, we don't really have any tertiary hospitals contracted within our service area. So a lot of times members are going, into Bend. Sometimes, up in the Northeast, they go into Portland, into Washington, into Idaho for specialty care. So these transportation services are covered benefits to take you to all those places. It also does reimburse for a hotel stipend and a food stipend if you do need to travel to some of these outlying cities, these bigger metropolitans for your specialty care. But yeah, this transportation benefit is a very widely used. It's a great benefit, especially for this rural area. And really, we did list all the numbers, but if you just call that broker toll-free number, it'll get you to any one of the counties that need help with.
Don't see Lake up there.
So as we said, in talking about specialty care, is that we do have access to a wide range of specialists. Again, most of them are not in the communities, and so folks do have to travel outside to get some of those. And we are trying to access more telemedicine so that those specialties are brought in. And so that's an area that we have expanded in terms of also with the use of technology and investments that we've made.
Janet, a comment before we move into the investments on the specialty care. I think it's important for people to recognize that specialists in the Bend area, as well as in Portland and other places, certain types of specialties, it's hard for anybody to get an appointment with them. So we do have contracts with them. I know this clinic was concerned a couple of years ago about not getting into dermatology, but now there's several new dermatology groups up in the Bend area. But, we can get a contract with them, but that doesn't mean necessarily that everybody's going to have immediate access. It's difficult to do that. Sorry, Janet, thanks.
No, that's a good point, Paul. I think, again, I think those of you that have that they have your own medical insurance, I know, to get a dermatologist in the area that I live, it's a 6-month wait. So,
Same question.
Yeah.
On the previous slide with the non-emergency transport, where for Lakeview or for North Lake, where are people, where are we coming from?
There's another phone number.
Okay.
There's a handout that they have at the clinics. And is the brokers on the number now? It used to list out separately Lake County.
They usually get dispatched. Yes. Okay.
Yeah, cool. Thank you.
That actually comes through. The reason why that Lake County isn't up there, maybe because we don't provide fee for service. However, the Lake County Senior Center provides NEMT for Gobi. So if you have Gobi patients, we provide transport for them. We're in touch with the brokerage. So there is one, if you have an open card, we don't do that ourselves. So that has to go through that.
Yeah. There are some nuances, that's why we put the number out there for people to call to get that information. So the next part that we want to move into was around the community reinvestment funds. And Paul, do you want to cover this? Do you want me to cover it?
Go ahead, you do that, and I'll chime in if I think you're missing something.
Okay.
He's got you back.
He's got my back. So in terms of EOCCO investments, we just wanted to show the folks, and I think this actually was surprising to all of us when we actually went through this process to see how much was actually calculated. This took a while to figure out. But so as I talked about earlier, patient-centered primary care homes we paid $39 million to support that across the region in order to get to that 90% number. There's also the shared savings and value-based payments, which was over 37, and then the community benefits initiative, which is just over 5 million, which again is something that you all heard about. And I'm not sure if somebody's on the phone, if you can mute, we're getting a little bit of feedback. And then we have the quality measure investments, which were 32.15 million. So total reinvestments to date were 114 million. And then
Janet, I'll just have a comment here on the patient-centered primary care home payments. It's important to note there that that amount of money was paid before a patient was seen. So if people were assigned to patient-centered primary care home, in their tier 4, I believe it's $23 now, or
21. It's 21, Paul.
20?
$21.
Okay, $21 per member per month that you're getting ahead of time before that member even comes in. That's to recognize that if you really are doing patient-centered primary care home work, that work, that it's costing you more as a clinic to do that because of the care coordination, population health management. And it was one of the first things that the EOCCO board determined right away is we invest in primary care. And it's primary care that's helped do the shared savings and meet the quality measures more than any other group. So I just wanted to point that out.
thank you. So in terms of behavioral health community investments, we have innovations projects that were funded, as well as youth and family investments that were made, and then community investments for another $11 million. And these are a range of services, including some of the school-based programs that are in parts of the region that help fund down, as well as a variety of other programs that people apply for in order to receive extra funding for. So that is a grand total of over 125 million that were reinvested into local communities.
Right, not counting the actual payments for consumption of medical services and mental health services and dental services. Those are reinvestments from returns from community quality measures.
Absolutely. So we were going to talk about Lake County specific.
Okay, so for those of us that have been on the board for, or in the LCAP for a while, I think we see a lot of this from obviously our local CAP being funded, but we have been very fortunate in receiving in Lake County a lot of the reinvestment opt-in dollars. And so this slide shows a little bit about how over time those dollars have added up and how they have affected our county specifically. So having a total reinvestment funds in Lake County of over $500,000 is pretty substantial, and that helped with a lot of different things and initiating programs that are still running within our county now. On our next slide, many of us are familiar with our Outback Strong branding. So the Outback Strong program is something that we have used a lot of different things to help support and as a platform to attract people to healthier living and to support a lot of the, while the incentive measures are great, it's better to look at them as these are preventative health measures that are making our community healthier. And I can speak from experience in seeing how much healthier our clinic patients were as a result of us doing the quality measures. Those were things that we were helping, we were starting to see them less. We started doing more flu shots, and lo and behold, the next year, well, gosh, our visits are down for the month of December. Well, that's because 300 extra people got flu shots, so they didn't get sick as much. So, we see those things that really are impacting us, and so it really pushes the staff and the health clinic to do more, and the facilities to want to participate. These are the dollars where these went in our community specifically. So the Go Girls and Women's Health Ambassadors, Youth Health Ambassador programs, Outback Strong for multiple years with positive norming using services and training staff. Our summer lunch program, which has been huge, we did 3 years. Yes, for 3 years, getting bigger every year. and that's going strong still. OSU Extension Triathlon Training, Lapine Community Health Clinic with the North Lake Fruit and Vegetable vouchers for children's programs. Arvinder was talking about our teen health fair. This was the third year for that. Great, obviously, with 52 of the 54 kiddos that they've looked at so far, I think that that's important. I mean, getting any teenager to agree to anything that sounds like it could even remotely be connected to health is a great positive impact for our community. Colorectal cancer screening, I believe many of you have met Nolan McCollin. He was a great hit at our daily days and a great addition 2 years ago. So some great ways for us to kind of that positive norming and to help people understand how important those preventative things are to lowering the overall healthcare costs. Our emergency department utilization and our navigator program, we've been able to have Kristen on board with us and to help decrease the emergency department utilization, and even now drilling down into specific types of patients that are utilizing the emergency department. So our Living Well programs have been huge. Diabetes control, hypertension, the pain series, huge positive things that have happened in our community. So the estimated medical spend they have on here as $29,244,000. And as these things have gone into place, I bet if we looked at that from 2014 to 2018, that we would see that those dollars have gone down. These are really things that impact our community in positive ways and help us to lower our overall costs on healthcare.
Okay, so we're going to shift in and talking about CCO 2.0, where Janet and Noah and our teams have spent our entire year working on. So I want to give a little bit of backdrop in that this process was not an easy one. I can tell you that the application that we submitted was over 600 pages long. And it required, just the breadth of the work that we had to do was overwhelming. And then we had a readiness review on top of that, which was another like 300 plus pages that we had to put together and go through a process. So when we're talking about CCO 2.0, I just want you to have that backdrop. It's taking what we were doing and really adding in a lot more reporting, a lot more expectations, and we're trying, part of the reason we're out in the communities is also to get feedback from all of you that we can also take forward as we're developing this. It is going to be a work in progress. So this is the org chart where we started, as I said, the chairman of the board, Robin, was also hoping to be here. And we're on our, what number is this? Number of presentations. I think we have 3 left. We've done 15 of these community presentations. And so you can imagine that this is taking some work for everybody's schedule to navigate. But we saw the benefit and really wanted to be out there. So you can just get a chance to look at those are the folks that are on the org chart, and underneath it you can see the complexity of all the things that we are required to do as a CCO that include everything from the operations, which is like how do you process claims, what are you doing around diversity, equity, and inclusion, which we have to have a whole plan for. We also have social determinants of health, which we are required to provide spending for. And then we have things like mobile crisis and assertive community treatment, all the way down over to, we've got the clinical advisory and care management, which is also expected to evolve and be very different from what we historically have done. And then things like appeals and grievances and counters. So you can see the complexity of all of the work that is required to do this. So part of what was added in for CCO 2.0 was these committees that are in kind of, I don't know what we would call that, yellowish, that we've always had these other committees as part of the structure of EOCCO, and now we're going to be adding these. And so the CAC nominating committee is one that is new, and we are working on a process right now of formalizing how that will work. And we're talking about this being bi-directional, so that there would be both those of you that are interested in potentially being on the CAC, the nomination would come through, and it would be bi-directional in terms of the communication that we would have regarding that. We do have to have a diversity, equity, and inclusion committee, and CCO metrics, member engagement, network management, policy review. And then we have this whole other thing called regulatory compliance, which is how we're going to meet all the new rules that we're required to comply with. And so that, just so that you know, this is adding in some additional complexity to what was already a pretty robust system. So the areas of focus for CCO 2.0, again, are that triple aim, which is better health, better care, and lower costs. And so part of what we had to identify as this process is areas that we would focus in on. And so we picked a few of the ones to share with you. We put these in our application and wanted to, get feedback, share these with the community so that you know what we are working on. So social determinants of health is something that that you can see from the range of programs that you talked about, especially around things like food insecurities. They're things that we have been very invested in and very concerned about. And so this is something, again, that we are looking at, things that we will continue to develop and invest in that include kindergarten readiness, that expansion of telehealth services, community health workers located in emergency departments. The naloxone distribution is something that I help oversee that program, and I will share with all of you that we have just gotten a huge response from the communities that we've been in. We are, I think we were just, the staff were just in John Day. I think we distributed 40 kits. Just alone, we've trained everybody from law enforcement. We've actually had the mills come up and say, we'd like to figure out how we could have folks trained, and could we figure out what OSHA might think about this, and so it's really expanded, I think, and we've been just so impressed and honored by the response from the communities that are stepping up and really want to get naloxone out into the hands of people that need it most. And so if you're interested in that, please let me know. We've got, we are doing basically a county by county pathway, distributing those and then circling back around. And so we've got a whole plan on how we're going to do that.
Add something to that?
Yeah.
We've been talking with Kelly.
Yes.
I'm about Kelly Butler.
Yes.
As part of our opioid grant we have from HRSA. So that grant allowed us to supply naloxone to all of our law enforcement officers in the county. Which is great. They covered our corrections department as well, but Kelly's going to be here, I don't know the dates, but it's the first week of December,
yes.
Over 3 days. So she's been working with, I know Public Health is interested in getting trained, the library is talking, but yes, please talk to Janet and or Kelly.
Yes. Yeah. We will definitely, and again, this was the first one we were in. We had an initial here's who we thought our target population is, and then it has just really grown exponentially, and so we're thrilled. And we actually, I have to say, we had our first confirmed case of a person that was actually saved by having the naloxone. So with that feedback came back to us. So that was really wonderful. And we're doing a statewide learning collaborative that we launched 2 weeks ago in partnership with the Health Authority and a number of other folks that will also knit that community together statewide. So, and then I'm guessing if this is the case across our whole region, is that safe and affordable housing is something that is the number one thing that we hear in every community that we're at. And so we are partnering and thinking about ways that we can expand that. We've done some initiatives around tiny homes, around some actual writing of actual ordinances around how communities can respond to ordinances that around tiny homes. And so that also is something that we've been looking at in what areas that we want to expand in. And then the whole expansion with the complex behavioral health needs, which is the expansion of medical assisted therapy, the pain school, and then the improving access to care, which is a no wrong door concept where people are entering the system that they don't get told, oh no, you got to go over here. And so we're working on that, and we launched that initiative last year, and we actually are writing a grant, a HRSA grant that would expand that And hopefully we're going to get that by March. And Kevin has shared with me the commitment of Gobi is that regardless if we get this grant or not, we are going to pursue the tenants that we're outlining for no rock door. And with that, some payment reform. So in terms of,
Jim, before you go off of this social determinants of health, we do have a couple of North Lake Health District board members here, and we may have some down there for the Lake Health District. But most of the health districts, and we have one in each of our 12 counties. Some of them are countywide, others are sub-areas of the county. Like in Baker, there's one to support the clinic in halfway. But most of the time, the health districts get property tax revenues and they funnel it into a clinic as non-operating revenue. They do the same with hospitals. But when you look at the legislation, we have organizational vehicles already in place to be able to do things like housing and food. You have the authority to do pretty much anything you want that improves the health of the population. And I'm not saying you want to do it, but there's an organizational vehicle in place already through the ORS, defining what health districts do. Thanks.
Okay. So in terms of community engagement, I think this is an area that many of you have hopefully experienced and seen. And that is the support to the early learning hubs. And we have the annual meeting and really try to look at that connection that we have. And we just had that meeting last month. Yeah. We also have, in terms of tribal outreach, one of the areas that we were required as a CCO is to have a tribal liaison, and that person is Karen Wheeler. And so Karen has been working with both affiliated and non-affiliated tribes. I want to be clear about that, and so her role is with the to provide that outreach for tribal members and coordination around that. We also, as we talked about, have the patient centered primary care, home support. Gobi does have a consumer caucus, which is members that have severe persistent mental illness or other behavioral health challenges that are part of a caucus that give feedback up to the Gobi board around behavioral health services, around the services delivery model and system, and they also give feedback directly to the board through our quality improvement committee. We also have the, as I said, the Behavioral Health Quality Improvement Committee, which looks at how do we engage communities, and there was actually a conversation today. We have a peer and provider, what is the A? Advisory Council. And they actually were talking about today that we're looking at probably merging those two together as part of our QIC so that we make sure that we have that member patient voice on the committees that we have that report up into the board. We want to make sure, as I said, that member voice is really clear in the work that we're doing and advocating that. And Paul, I don't know if you want to talk about some of the challenges around membership for the CACs. Did we lose you, Paul? Okay, I'll keep going. So part of the challenge is making sure that that member voice is present in all of our community advisory councils, and so we're striving for that 51% membership, and so that's something that we continue to work on. Health equity is also an area where we've got some work to do around making sure that the information that we send out to members is appropriate and that is understandable and clear. We've gotten some feedback, I will say, through these community meetings about our website that we took to heart, and Patrick and other folks have been working on updating the website. I got we have another Patrick that works on this as well, and I got what do we do? This isn't clear. We have to fix this now. And so we had a 2-day deadline to turn this around. So I just want you all to know that we're taking that information and really trying to make sure that we heed it and take it into account and fix the things that aren't clear.
And it's a team effort, of course,
Oh, yeah.
with Moda and Gobi working together. We're
Yeah.
really taking a look at that site and how it can be more user-friendly.
Yeah, and part of what is coming is, do you want to talk about, Summer talked about this age-specific?
Oh, yes, on our website, under the members side, it will now be broken up by age-specific choices. So if your ages 0 through 16, or 16 to 18, or 18 to 21, and then up to 65, that have been broken out specifically. So all you do is have to pound down on the age that you fall in or that you're looking to find out information on, and it'll give you specific information there. So for instance, you know, turning 18 as a child on the Oregon Health Plan, they need to re-enroll as an adult, so information won't be found there. But on the other spectrum, 65 and older, as we know, that's transitioning into Medicare, where you possibly could also have Medicaid as well, so there'll be information on how to go ahead and get enrolled into Medicare. So that will be rolling out in 2020 about the age-specific information on the members side.
And we certainly appreciate that, and in the bigger context of why that was created, our clinical advisory panel, we're really quality payments there, because it's based on how many people are assigned to you, right? And you have to meet the quality measures for those people. But the fact is, in North Lake County, those members that we have, 44% of them consume no primary care service. So out of 72 people, 42% consume no primary care in 2018. How are you supposed to provide a guidance on colorectal cancer screening to somebody over age 50 that's a member of the plan? How are you supposed to talk about effective contraceptive for women between the ages of 15 and 50 if they don't come in? In South Lake County, it was 41%. So this thing that says you're a female between this age, here's the things that you need to do to use your benefits and have the primary care system help. So that's the key to this. I mean, we need people to use the service, believe it or not.
There's no evidence that the telling us 4% of the care, 2% of
no, if they went anywhere for primary care, any place that we have a contract, it'll show up. Yeah, this is a cost and utilization report. You know, our regional community advisory council said we can't believe these numbers. So, and who are they, right? So what we did was, with the data sets, we broke down the members, and just for North Lake, since I'm here with these folks, I'll tell you where the age cohort is. It's 25 to 44 years. Although we do have a lot of 5 to 15-year-olds too that don't come in.
Well, I think even at the local level, we struggle with that. I know we do a lot of outreach to those patients that are assigned to our primary care home, and even despite phone calls and mailers and postcards and everything, it's still a struggle. So the social norming and getting people engaged and making the website easier to understand, those are things that hopefully are going to help encourage those people to utilize it and to have that population health outlook that you want to seek care before you're sick.
Right, and I think that's where Outback Strong comes in, is to try to create a different community norm around it. I mean, the theme that we hear in Eastern Oregon is, you know, Cal Fill or Cal Floyd up. You know, I mean, unless there's flood, you're not going in. You know, and what we got to do is kind of change the mindset that, you know, an adolescent well visit is a good thing to help the kid get healthy and long term. And, you know, it's the community promoting that that's going to happen. But, you know, that's the new piece of the website, is to actually encourage utilization.
President Martin.
Oh, so if you could go back, I just want to touch on, so one area that I think you all hopefully had some exposure to was that we had to do the community health assessment, and then out of that, do the community health plan that was shared with the CACs. And one of the challenges that we have going forward is going to be, how do we make sure that there's alignment? One of the things that is being asked of us in CCO 2.0 is there are a lot of plans that we're going to have, and this actually came up at one of the Transformation Center trainings that I was at, was how do we make sure that there's alignment? Because the health district also has to, everybody's got a plan that they have to put together. We now have a behavioral health plan that is included now that went away for a couple years. And so one of the goals that we want to make sure, and that's also part of why we're here, is also just to say we're going to need your help. We're going to need your help to make sure that there's alignment in these plans, that for the diversity, equity, inclusion. One of the things that I found from talking with the public health folks is that as part of their process, they've also been working on a new plan. So how do we make sure that those goals that are in that plan also align with what we're promoting with our diversity, equity, and inclusion plan? So part of this is going to be some work to making sure that these are conversations that we're all having and that there's linkages. So, and that is, again, just awareness for all of us. So the other part that we are looking at is with value-based payment. And this slide just basically talks a little bit of the history of what EOCCO has done regarding that shared savings model and how that was linked to primary care. And then it basically, the goal by the end of 2024 is that 70% will be value-based payments. There are multiple efforts going on around this. And I wish that Kevin and Sean were here because they would be the ones to talk more about this. I can tell you all about the community stuff and the services, but it is something that we're actively working on because we want the payment methodology also, we know, informs the care that people receive. And so trying to make sure that we're paying for value and not just paying for a visit, that as we talked about, that we've got people coming in, as Paul said, that preventative care is something that we really want to get to. So that's something that we'll be actively working on. So the health information technology is also something that this is an area that we have seen tremendous growth in. And so I want to talk a little bit about a few of these, and we're almost done, so because we want to save some room for the end. But one of the things that we have had to submit was this roadmap, and a couple of the things that we've invested in are, one is called MEND, which we have been utilizing, that is a platform to get behavioral health services out into a member's hands, basically using their phone or other kiosk models so that we can get specialists and get people connected that may not be able to come in or want to come in. I think one of the best stories that I heard was actually in Union County with a member that was having agoraphobia, which is a fear of being in public places, and was able to use a MEND platform to get connected with a clinician. So again, allowing accessibility, and that's one of the areas, and also with youth who use technology. And I know that when we first, in the clinic that I worked in, when we first tried this technology, kids were much more easier with being on the, using the phone in order to receive services, and so it is an area that we're expanding. We also have a platform called HMS that we're using for care coordination. And again, we're looking at an expansion of being able to provide care coordination services to members. And then we have this Facet, which is a program that MODA uses to pull in all the claims data, and that's what we use then to look and extrapolate a number of reports. Predictive analytics and things like that are built upon that platform. And then we have a platform called MyStrength, which is actually something that, so Trace, are you using MyStrength? Because I think it got promoted out here.
I personally am not using it, but I know a lot of our staff are.
Okay, so MyStrengths, and I have the login if anybody is interested. It is basically it's an app on your phone that you can get, and we want to encourage people to use this. I said in the meetings that I've been at, I have had some challenges with sleep because of all of the work that we've done, and so I actually use the app to log my sleep, and it has little activities that you can do around your sleep, and it includes early, so in terms of thinking, they also have like parenting, so for new parents about, there's videos, it's really self-guided. And so you put in what the goal is that you want to work on, and you can then create a plan, and they'll send you reminders. So I get on my phone, did you log your sleep, and how was it? And And so it's just an area that we really want to, in terms of people being able to take advantage of in our region. And then we have something called Arcadia Analytics, which is basically where, again, another platform where we can do a lot of analytics and pulling in both electronic health records and our claims data together. And we have actually 12 healthcare systems and 11 behavioral health programs currently connected, and our goal is to get them all connected by 2024. And I think, again, where that will come in is that we can then look and see, because we'll have the behavioral health data and the primary care data, and we can look. And so if there's a member that's coming in and say that they need a test or a screening and they haven't had it, it will allow that to be flagged and people to go, oh, by the way, we need you to get in and get that. How can we help you? Yep. How can we help you do that? The other thing we're working on is electronic health record adoption for public health. There are some glitches with that we run into recently, but we're still working through them. The platform that we thought we could use, there are some challenges with it, and so I think they're going to go in a different direction, but we're still working. And that is an active area that we're engaged in trying to create some solutions to. And then many of probably have heard that we're using the, with emergency department, EDI or pre-managed utilization across systems. And so again, that expansion of getting information when somebody comes into the hospital, that would get flagged, and there's a care plan associated with that, and folks know what the discharge is and what, if there's anything that needs to be highlighted, that they get that access to that information on a timely basis. Then for behavioral health integration, we are looking at bidirectional integration. Again, that's where counselors at your doctor's office and doctors at your counselor's office. And that's an area that with CCDHC, which is Certified Community Behavioral Health Centers, we are currently implementing in parts of the EOCCO region. We're also looking at value-based payments. We have the collaborative care model, which again is helping with, and that's something we're actively working on here in Lake, is to get that established so that there's basically a registry created and there's consultation and looking at measures around how folks are doing. And then we have, again, the intensive care coordination, which is expanding, and we have a whole range of requirements and expectations that the state has asked us to do around that. And then, as I said, this behavioral health plan that will be due in March of 2021. So that was a lot. And I know that's a lot of information because I had to help put this together. So what we'd like to do is just take a few minutes and see questions, feedback, comments that you all have, things that you might like to know.
What's working for you, what's not. Yeah. This is the time to share the feedback so we can bring back and how to better improve our policies.
I had a question about the CAC nominating committee. So the committee is going to be from people from all the counties?
Right now, the thinking is that the local community will send up the application to a group that will be EOCCO. They'll review it, and what we're talking about is, because of the relationships with the commissioners, is that we'll also have a mechanism to let them know that we've got a member, that there's buy-in, and then it will come back in.
Is anyone concerned about value-based payment being at that level that soon? Is that something that there's going to be a lot of support around? Because we are certainly not a fee-for-service facility, and when I start hearing value-based payment, I start wondering how that's going to impact us financially and our ability to provide that level of care to the number of patients that we have assigned. Is there going to be some more support or education, or how do we plan to obtain, to get to that level?
Yeah, I think that is part of it. This is going to be a process. It's going to be a rollout, a sequential process about how that's going to be established, educating, informing, and getting feedback as we move forward. This is something, again, I was just, yeah.
And currently, right now, Lake Health Clinic is on a capitated model.
Yeah.
Right. So when they come in for the PCP services, it's capitated, and as well as their integrated behavioral health has already been kicked off for Lake Health since September of last year.
Yeah, I think part of it will be the challenges around what is the value, you know, and how we're gonna define that. So but I would encourage any of you, if you have concerns or if you have suggestions, please share those, you know, because we're really, that's part of this, is that we really want to hear from all of you around, you know, what are the areas that you're concerned about, what are the areas that you think, whoa, make sure you pay attention to this.
I saw under the social determinants slide, there was something about supportive housing. Do you have any information on what CCO 2.0 is going to do for supportive housing in the county?
Yeah, there was actually a guidance document that was created by the Oregon Health Authority, and I think that we'd be happy to share that with you. It is relatively new, and so we're still going through that, but one of the challenges is that it will not allow Oregon Health Plan dollars to be spent on bricks and mortar. And how you define short-term and support, all of that. So it's kind of laid out that there's a laundry list that they've given us about things that they think would be okay to pay for, which would be like background checks or application fees, things like that. And then there's a list of things like, no, you can't do that. But there's lots of gray in that. And so it's an area that I think we're going to be working through over the next couple of months just to get clarity. And we did ask the state for some additional guidance around that because there is a lot of gray.
So you wouldn't have an estimate of how much funding is going to be necessary for supportive housing?
No.
Yeah, not at this time. It is a work in progress. I think the biggest thing out here for the rural areas is, you know, now the state has given us all this money to kind of help address this issue, but what if there is no housing out in these areas? So that's one of the big gray areas that they're trying to work through, because now we got all this money and we just need to figure out how we can do it if we're not allowed to help build the housing.
Yeah, and I would say that there's not, that they've allowed the funding, not that there's this not new housing pot of money, but they've allowed funding to be spent in these areas. So that's a distinction there.
So like you mentioned tiny houses and things like that. I know North County, like South County, there's a lot of people in RVs and things like that. Does that count as a tiny home? Or is that, I mean, it's basically the same thing.
Yeah. I think there are a number of communities that across the state that are moving to building tiny home villages, basically. Right. Yeah. Right. So that it would be supported and funded, but you've got to get multiple housing streams, you know, fundings and, you know, people connected. What we ran into, and this was actually in the grant, where we ran into an ordinance issue, and that's where we worked with some folks around the ordinance so that they could actually be built within the city. And so those are some of the challenges that the communities are running into. But, yeah.
So that is something we have in Lakeview. Our town codes have not been updated for who knows how long. And so some of the projects that we're looking at around supportive housing, transitional housing, multifamily, anything are not technically legal right now. So if you could maybe help with consultants or something to help us figure that out.
Yeah, we've been working with Pinnacle Engineering out of Bend, and they've been consultants for us around this, and we would be happy to share the ordinance if you just let me know. Okay. And we actually, so I want to give credit to Meyer Memorial because they actually helped fund us in order to get that, the work that they did around the ordinance, but we'd be happy to share the ordinance.
Janet, this is Paul. I'd be remiss. Remember that Oregon Health Authority asked us to ask communities if there was anything specific that they wanted to talk about. And when we discussed this at the last local community advisory council meeting, there was comment about what will CCO 2.0 have to do with workforce development, including more primary care and behavioral health?
So there are a number of initiatives that we are engaging in, and workforce development is definitely a critical area that we recognize. We actually, as part of the EOCCO leadership this week, that was a part of the conversation. And so there are going to be a number of initiatives that we look at. We're already partnering with I never get it right, Paul, help me out. It's Eastern Oregon, it's the health education, oh my goodness. Yes.
Sorry, I couldn't get off you fast
Yeah.
enough. It's very health education centers.
Yes. So,
There's a number of them that work. There's one in Northeast Oregon. There's a couple in our service area.
yeah,
Where Lake County is generally one out of 6 Charles.
okay.
This is, main intention is to have younger people be able to get basic sciences so that they can enter into medical professions and compete, so that rural people will come back to a rural area. So, I mean, that's the idea, give them a head, it's like Head Start, it's for medical programs or mental health programs.
Right. Yeah, I think part of the we are looking at telehealth options. I mean, it is a reality of what we have is that many of the people that we can get, and I'll talk about for some specialty areas, are out of the Portland area. I mean, it's just, we struggle, we try to get them out here, that's been our engagement, like come out and see, and I know many of you have great programs and like, you do like recruitment. And so part of what we're doing is looking at both. We need to have multiple strategies. So one of those strategies is how do we engage some folks that are maybe more tied into a more metropolitan area, and how do we get them so that there's a connection. And so part of what we've been working on is sending some of the staff that we have currently out into the communities a couple days a month, and then they do the rest of it telehealth. And so those are just being creative about what resources that we have and capacity that we have.
Jim, there was a sidebar conversation up here when you were talking about the men's platform. Has it rolled out in Lake County yet? Is Trace there?
Yes. Yeah, it is.
Okay. So it's here. We can start trying it now.
Yes. Yes, it is. And if that's an issue, just let us know, because they're a designated site. And I should say for men, this was a HRSA grant that we got. We're actually we got the grant as a demonstration basically of rural communities that are struggling around connectivity. And so we actually have to, Trace has to, they have to track like what's the distance of the person that would have had to travel for an appointment. And I'm actually really proud to say that of the demonstration pilots that are out there, we're actually leading that initiative with a number of telehealth visits that we are currently providing to folks. So, but yeah, workforce is an area, again, if there's suggestions or recommendations that you all have, or areas that you think, well, you're really missing the boat here, you ought to, think about this, please let us know. I mean, we've thrown out like tons of different ideas and suggestions, and how could we're thinking, how do we partner with different universities, how do we get people out into our communities, how do we market that, rotate, all of those things, so that we can get folks to come out here and see the value of working in rural communities.
And one last thing, the My Strength app, how much does it cost?
It's free.
Oh, it's free.
It's absolutely free.
Is it able for us to plug that on out by Strong?
Yeah.
That's something that might do a good business. It might be something that would be useful for our.
Yes. Yeah, we would like to promote it. So we pay on a per member basis for those, and we're not seeing the utilization that I would like to. I'd love to see an increase in it. So so we're actually tracking now, since I'm going out and we have staff promoting this, like, are we going to see an uptake in the number of folks using it?
So you're paying for it according to the membership, but is it open to
Yes.
everybody?
To the broader community.
Yes, yes, yes. And we're promoting it for providers. That's why I tell everybody I use it. It's just something that, again, that we think is a nice tool to be able to utilize. That's pretty. They've done a lot of work, and a lot of thought has gone into this application. So. Paul, are there any other questions there or on the phone?
Yeah, there is one, and it's about the distance to a pharmacy here in North. Dr. Allen, I'll let you just say the question.
Oh, I don't know if it's a broken folder, but have 19 prescriptions approved for our patients here in the North Lake County. It's a hardship to drive to the pharmacy, an hour and a half to get the provider a little bit further than Lakeview. So having them ready in Pearson, Rose Bay, or Bishop Water Apple.
No, I'm not sure whether you can address that one or not.
Yeah, and that would be something that we have to take back with our teams to find out if there is any other pharmacies. I know for the OPDP, it's only specific pharmacies for EOCCO that we contract with, so that would be something we'd have to look into to find out if there's anything else viable. I know there isn't any mail order or anything for EOCCO as well, so I know that's a hassle. But it is something that we can look into, and I can bring back to Sean and Summers.
Yeah, I kind of remember an early discussion at the clinical advisory panel on that, but I don't remember the result. The other thing is just as a stupid question, for non-emergency transportation, will they take you to a pharmacy, or does it have to be to a provider?
I think it's got to be a provider, it's got to be a covered medical appointment or a covered service for medical, dental, or behavioral health. But a community health worker can help with that.
Before they bring something in, I didn't know if you could just go to the pharmacy only and operate, so we'll look into it.
Yeah, I think that is a great recommendation that we can take back to the clinical advisory panel. That's exactly why we're here, so that we want to find out what those barriers are, if there's something that we can do to alleviate that or create solutions, or if there's, that there has to be a workaround for a specific area. That's what we would like to take back. Again, I can't promise that there would be.
Thank you, Janet. I don't think we have any more questions up here, so I'm going to go on.
Okay, is there any on the phone? Did we lose everybody?
Do we have any other community involvement, public comment? Anything of that nature?
I think one of the things to just kind of bear in mind, telehealth is great, and doing projects like that is great for rural counties, but you have to remember it is a rural county. Your service is sketchy, to say the least. In most areas, most of our deputies can't communicate with each other most of the time. So that's just something to be cognizant of. It's not anything that anyone expects you to be able to solve, or anyone else, but it's just something that we're working towards, being aware of the breakdown of communication and the barriers and that. It's just something to keep in mind.
Absolutely.
One of the other things that we've been discussing a lot lately is we all have, everywhere, statewide, countrywide, is the mental health professional shortage. And it takes so many hours for them to be able to accomplish that education. Is there any look towards possible funding for facilities that are, we have people that are doing their clinicals or their, whatever that process is, so that, we can't bill for their services, but could they still be, it's hard to work all of that time without being really employed, or the facility is paying the employee and they can't bill, they're not being reimbursed. Is there any look towards possibly subsidizing that to help make it more appealing both to facilities as well as graduates, or anything?
Yeah, there's some loan repayment programs out there, and the state has had some success with some of those. And so I'm not sure that in Eastern Oregon that we've been able to take full advantage of some of those programs, because they require a lot of steps. And you have to go through an application process, and you have to sign off on it, and you have to agree to all of these things. But there are a number of programs that are available in order to help support that. And that's something that actively, we're trying to figure out, how do we tap into that? How do we educate people? How do we say, oh, and by the way, I was involved at one point, we have a psychiatrist shortage, and Kevin will tell you all that, we have a psychiatrist at Covey that's a child and adolescent psychiatrist. He says there are unicorns. There are very few child and adolescent psychiatrists in the entire state. They just don't produce a lot of them out of the schools. We've advocated with the school. We've gone to the school and said, could you do more? We need this in our communities. We need, and so there are ECHO projects now with Oregon's only just you, in order to get that expertise out. There's a number of different things that people are trying to work around. It still doesn't help with the shortage and getting this done. But I think we have to keep working on it and keep trying to figure out creative ways to solve it. Have you ever done an MOU?
Yeah, and we've done at least one, maybe more. Okay, well, if nobody has any more questions or input, we'll go ahead and adjourn the meeting. Thank you all for your time, and